Okay, thank you very much for having me today. I hope you all can see my slides. I'm going to get going. Sorry. So I titled this presentation, What You Need to Know About Colorectal Cancer. I want to be very, straightforward, kind of keep things a little bit simplistic, but give you a thorough understanding of what colon cancer is, how we detect it, and how we can treat it. So our objectives are to go over the incidence of colorectal cancer, to look at some of the risk factors that can lead to colorectal cancer, review the various screening options, and then emphasize the value of colonoscopy. And lastly, I'm just going to touch on some surgical technology. And I just want to explain, as a colorectal surgeon, I do mostly the surgical aspect of it, but a part of my practice, about 2 days a week, I spend doing colonoscopies, which helps detect colorectal cancer. So colorectal cancer is the second leading cause of cancer-related deaths in the United States. Each year, about 140,000 people in the United States are diagnosed with colorectal cancer, and 52,000 patients unfortunately die of it. Men are affected at a slightly higher rate at 4.3%, and women 4%. And that's throughout your whole lifetime. The death rate, luckily, has been declining over the last 20 years, and we think of screening measures for allowing us to catch cancers earlier and cure patients. Current screening guidelines enable us to recognize these precancerous lesions, which we call adenomatous polyps, or we just refer to them as polyps, which is what you've probably heard in layman's terms. Screening can help prevent development of colorectal cancer and identify those patients that are at risk of forming these polyps more quickly, which we just call a fancy term, accelerated carcinogenesis, meaning you're a polyp former. So just before we get into details, I like to review the anatomy, because sometimes we're not clear what is the colon, what is the rectum. The colon is this big, sort of like an upside down U-shaped organ that lines your abdominal cavity. It's what the small intestine then empties into. And then as it approaches the anus, it turns into the rectum, which is about 15 centimeters long. So it's one continuous organ, and it's what's surveilled during a colonoscopy. And then just getting a little finer details, I just wanted to show you, this is a cross section, or if we were to cut the colon up and down, you would see inside of it. And it's that inner part that we're talking about. That's where the polyps form, that's where the cancers originate. So this is just kind of showing an up-close view of that, as opposed to the polyps forming on the outside, it's actually on the inside. So what is the function of our colon and our rectum? Well, it is an organ that we can live without. Its main function is to absorb water and electrolytes, and it provides additional storage for those things that we can't digest. So it's not doing so much absorbing nutrients like the small intestine will, but it does these functions. So how does colon cancer even come about? Well, we're born with nice normal mucosa, which again is that inner lining, the lining inside the lumen or the opening of the bowel. And over time, when cells replicate, they can form what we call polyps or adenomas, which are just abnormal growths. At that point, they're not cancer, but if we detect them, we can remove them and help prevent them from going down the line to what's cancer on the right side of the screen. So I want to emphasize that most colorectal cancers do not have any symptoms at all. So many times I see patients in the office, in the hospital, that say, I've been eating healthy my whole life. I exercise every day. I've been feeling great. Well, still not a great reason to avoid your colonoscopy. Advanced cancers, those that are unresectable or uncurable, they can cause bleeding and pain and constipation or diarrhea, and unintentional weight loss. But you want to catch these early, so you want to catch them in the asymptomatic state for your best outcome as a patient. So it's just, again, another diagram showing, if you look all the way towards the left, stage 0 would just be a polyp or a benign growth that during a colonoscopy we could find and take out, and that's just a very, very minimal procedure. we do it at the time of the colonoscopy and you don't feel a thing, to a cancer, which is stage 1. And then as the cancer progresses, it invades more of that organ, the colon, more into the wall. So that would make it a stage 2. And then when you start getting into stage 3, it starts getting into the lymph nodes. And lymph nodes are just little organs that line other organs and filter out the blood and can catch cancer cells. So as cancer progresses, it gets stuck in these lymph nodes. And then stage 4 cancer is when it leaves the colon and goes to other organs such as the liver and the lungs. So again, just want to emphasize that we can catch these things before they start getting invasive and when they can be removed with very minimal impact on your health. So how can we prevent or at least better understand our risk factors? Well, there's certainly risk factors that we can't change, and knowing your family history is key. You can't change it, but having that awareness can help you get screened at a more appropriate age, which may be earlier depending on your situation. But there's some factors that we can modify. Quitting smoking is certainly helpful. Trying to limit your processed meat intake or your red meat intake. I try to keep down to 1, maybe 2 times a week of eating red meat. You don't want to have no quality of life if you love to eat burgers and steak like I do, but everything in moderation. Staying physically active is helpful. Dairy products, fiber, all those things are helpful. And then people, unfortunately have pre-existing conditions such as Crohn's or ulcerative colitis that could put you at a significant increased risk of colorectal cancer. And usually once you're seeing a physician for that, they're letting you know that you need your colonoscopies every 1 to 2 years after you've had that disease state for 8 years. But again, that's a little more detailed conversation. So I think with this slide, the takeaway is that do your best to be healthy in moderation and know that your risk factors either do or do not exist, and do your screening based on those factors. Okay, so how do we prevent colorectal cancer? How do we make sure we are not one of those poor, 4% of patients that develop it throughout their lifetime? Well, screening tests. Screening tests in general are designed to determine if an asymptomatic patient has an undetected condition. So if you think of mammography, that's a great screening test. It's widely adapted. It's desirable for these screening tests to detect the disease at a point in which you can treat it and that treatment is advantageous as opposed to waiting till you have the symptoms and then treating it. We want our tests to be safe, sensitive, meaning that they're catching a lot of patients with the condition, affordable, because the healthcare system has to be able to afford this for all patients, widely available, address a major public health problem, which certainly colorectal cancer is, being that's the second leading cause of death following lung cancer deaths as far as cancer deaths go, and have treatments that are available to every patient. So when I think of colorectal cancer prevention, I think of 2 types of tests. I think of the stool-based tests and the visual exams. The stool-based tests look for blood that's in your stool. Typically, they're performed yearly. Maybe your primary care doctor has recommended it, but unfortunately, they're not sensitive, meaning that they certainly don't catch many polyps, and they certainly don't catch all the cancers. The range, depending on the test, can be anywhere between catching up to 70% of cancers, and for polyps, it's very, very poor. Also, there's stool tests that will look for blood and cancer cells in the stool, which you probably have heard of, something called Cologuard. This has been promoted widely through television, through primary care physicians. It's a test that's performed every 3 years, but it's only reserved for average risk patients. It's not therapeutic, and it has limited sensitivity. And then there's the visual exams, the gold standard being colonoscopy, which is performed between every 5 to 10 years, and it depends on the guidelines that you follow. And then there's also CT colonography, which is every 5 years, but the colonography, that's just a series of images. You still have to do a bowel preparation, which we'll get into, And it's just a series of x-rays that can find polyps, but once they do, you still need a colonoscopy. So I can't emphasize this slide enough that anytime you have any abnormal test that was listed on the previous slide, you still need a colonoscopy. And unfortunately, the way that insurance works, a lot of times once you have a positive stool test or a positive Cologuard, insurance won't cover that colonoscopy because it's no longer considered a screening exam. It's now considered a diagnostic or a test that we did because we detected a problem. So I know I stated that Cologuard's for average risk patients, but I didn't really define what average risk means. Average risk means that you have no family member, no first degree family members with colon polyps or colon cancers, or no more than one family member who's a second degree relative with colon cancer. It's performed, like I said, every 3 years. The convenience of it is that you do it at home. The company sends you a kit, and there's videos online describing on how to collect your sample. You collect large stool samples, and you send it into a laboratory. So they look they do different tests to look for DNA within the stool that's associated with colon polyps and colon cancers. So we talked a little bit about average risk, but just to go on a little further, not only does it emphasize your family history, but you can't have a history of inflammatory bowel disease, which includes Crohn's or ulcerative colitis. You don't want to have a history of hereditary colorectal cancer syndromes, and you yourself cannot have a personal history of colon polyps or cancers. So you really have to kind of interpret all of these results with caution. So where did they decide that this is, an accurate or safe or effective or worthwhile test? Well, there was an article in the New England Journal of Medicine many years ago when it came out. And at that time, the screening age for colorectal cancer screening was 50. So the study was based on that. They looked at 10,000 patients that were 50 years and older who were quote at average risk of colorectal cancer. And that's why, again, this is only reserved for that patient population. And of the patients who had a positive Cologuard test, only 4% of them actually had cancer. 20% had what I call advanced adenomas, which just for layman's term, large adenomas or large polyps that are more likely to turn into cancer. 31% had smaller polyps, and 45% of patients had absolutely no polyps or adenomas at all. So just imagine that you do the stool-based test, you're told that it's positive. A lot of patients get really anxious, like, oh my goodness, I could have cancer, whereas 45% of them actually don't have anything at all. 13% of patients without colorectal cancer or polyps did receive a false positive, and 8% of patients with cancer received a false negative. So that's really scary that, God forbid you have cancer and 8% of those patients are actually told that their study was fine. So colonoscopy, again, it's considered our gold standard or our best test. It allows for us to fully visualize that inside of the bowel where the polyps and cancers form. And at that time, as long as the lesions are, small, less than 2 centimeters or so, we can remove them at that time. It has led to a major risk reduction in cancer incidence and mortality. So screening guidelines have changed. In 2018, the American Cancer Society updated the recommendations to include screening starting at age 45 for, again, average risk patients. And when they recommend that you continue these screening parameters until you're 75, or if your life expectancy is less than 10 years. So if you're 60 years old and unfortunately you have heart failure and diabetes and kidney failure, then, at that time we wouldn't recommend a colonoscopy. But at the same time, if you're 85 and you are in the best shape, of your life and you could live to be 100, then we'd still consider doing a colonoscopy. This is a slide that shows a map of our whole country and the percent of adults that are up to date on their colorectal screening guidelines. And you can see this is from 2018, but you'll see New Jersey at 68%, which isn't bad, but we would like to get this up to at least 75%, if not higher. Understanding education needs to be emphasized and resources, but just to kind of give you an idea of where the country stands and who's doing stellar and who needs to kind of pick it up. So you might be asking yourself, why did the guidelines change? Why did it go from 50 years of age down to 45? What the heck? Well, what we found is that there's been a 51% increase of incidence of colorectal cancer between the years of 1994 and 2014. There also was an 11% increase in mortality between 1995 and 2015. And most frightening is rectal cancer incidence has doubled between 1991 and 2014 for patients aged 20 to 49. They also noted that there's a similar prevalence or incidence of large polyps between patients 45 to 50 as there are for those over 50 years old. And they also predicted that our current capacity should be able to accommodate this need for starting colonoscopy 5 years sooner. So for those of you who have not undergone a colonoscopy, it could still be a mysterious process to you. The worst part, I tell everyone in the office, is the day before the colonoscopy. That's when you're doing your bowel preparation or when you're cleaning out your bowels. There's a whole variety of medications that we use, anywhere from what's called Go Lightly, which is a big jug of medicine, to what I use now is called Clenpick. That's a prescription-based medicine. That's just 2 5-ounce bottles of medicine you have to drink, while at the same time you're drinking fluids such as Gatorade, chicken broth, Jello, other things to keep you hydrated so your electrolytes or your sodium and potassium don't get out of whack. So once that part's done and you have your diarrhea, that's the worst part. You've gotten through it. The next day following is the day of your exam. You don't eat or drink anything that day other than essential medicine. And you need a ride to and from, I do it at Valley Hospital, but there's certainly other centers where these are performed. You do get a sedation for the exam. It's a medication called propofol through an IV. It makes you sleepy, so you fall asleep right away and you wake up very quickly afterwards. There's no side effects such as nausea. It actually prevents nausea. And most patients don't have any discomfort at all when they wake up. And that's because we use a gas called carbon dioxide, which you absorb very quickly. So while you're asleep, we kind of inflate your colon with that carbon dioxide and then look around, look at the whole colon and remove any polyps as needed. So you should wake up feeling like your normal self. You take your ride home and then you resume your normal activities other than driving until the next day. After the procedure, you recover in the recovery area for about 30 minutes. And I make sure I see all my patients and I give them a nice printout of all the findings, some images, just so you understand what you went through. And then based on those results, we decide when you need another one. Most patients that feel very anxious about the exam because they've never had it done before, it's just, it is a procedure, can be intimidating. I've had every patient says, you know what, that wasn't as bad as I thought it was. Some people actually feel better afterwards because you've gotten a bit of a cleanse from the whole process. And if, you're kind of indifferent to doing it, think of your family, because if you have children, you want to know, are you a polyp former? Are they then at risk and need to start colonoscopy sooner? It's really a great wealth of information for your loved ones as well. Okay. And then, I talked about determining when you need a repeat colonoscopy based on the findings, but God forbid you have a large polyp that we can't safely take out during the colonoscopy, or God forbid you have a cancer. At that time, I would tell you the news and then we would take it step by step. We'd meet in my office. We'd go over staging protocol. We'd go over surgical options. And that's the beauty of having a colorectal surgeon doing your procedure, is that continuity of care. But certainly gastroenterologists are fantastic. I work with a whole slew of them at Valley, and they send patients to me and we work hand in hand. So I just wanted to quickly touch on surgical technology, and this is, where my training really comes in. Like I said, I did my general surgery training, 6 years of training at Cooper Hospital down in South Jersey. And then I went and did a fellowship in minimally invasive colorectal surgery. So I've done a lot of robotic surgery. You'll see on the left side of the screen, that's called laparoscopic surgery. That's still minimally invasive, but as technology has advanced, you'll see on the right side of the screen, the robotic equipment. And, what we do is we still make incisions in your skin. We're still putting devices in, we're standing bedside doing all those things. But once we hook up the equipment, we sit at a console, which is kind of like a station. And the advantage there is the robot has better optics. And instead of having like stick unjointed instruments, there's jointed instruments. There's a lot better mobility and visualization. And that allows us to do, here's just a few more images up close, the bedside surgeon and a surgeon at the console. And so what that does is it allows us to have better visualization in spaces that are tight, such as the pelvis, especially for rectal cancer, which is a difficult entity to treat. It allows patients to have earlier function or earlier returning of flatus or passing gas, and which leads to a shorter hospital stay. It also leads to a reduction of scar tissue when compared to a big open surgery with a big incision. That our incisions are much smaller, which reduces the risk of hernia and wound infection and pain. And for rectal cancer patients, it gives us a higher chance of putting the bowel back together and avoiding temporary bags or ostomies. So in summary, colorectal cancer is common yet preventable. Screening colonoscopy saves lives and helps direct screening protocols both for yourself and family members. There's a program at Valley, which we call the Fast Track program, which you can visit online at this link. The way that works is instead of coming to visit me in the office and kind of going through this discussion one-on-one, you can talk to a nurse practitioner or a PA about your risk factors. And if you're a healthy patient, then sometimes they'll just clear you to go through this fast track program and we don't have to meet face to face. You just come in for your colonoscopy. And then, we still meet you before the procedure. It's just not a 30-minute office visit. So that's just to kind of encourage patients to come in and make it easier. The other thing I wanted to bring up is, we work every day of the week, but I also do colonoscopies on Saturdays. So if your work schedule is ever too tight, you can always do your bowel prep Friday night and then do your colonoscopy on a Saturday. I just want to thank everyone for your time. I think this is an extremely important subject. You can save your life, you can save your family members' lives. And I definitely encourage my patients to spread the word, especially with, all the publicity that colorectal cancer has been getting recently.
Thank you, Dr. Friedman. We're just going to just switch over to Lee Slagle-Leeds, who's going to do the piece on dietary.
Okay, I just need Robin to stop sharing her screen so I can share mine. Perfect. Okay, so I'm Lee Slagle-Leeds. I'm the dietitian over at the Cancer Center in Paramus. And I'm just going to talk a little bit about good nutrition practices to help reduce your risk of colon cancer and all that good stuff. So what I hope to answer in this presentation for you is what foods should you avoid or limit to prevent colon cancer? What foods should I increase to prevent colon cancer? Can or should I drink alcohol? And also how active should I be weekly? Because nutrition and fitness kind of go hand in hand. So I have all my patients come and ask me, what do I need to avoid? That's always their first question. What do I need to avoid? So I figured we'd start with what to avoid and then work our way to what to increase. So red meat or any animal that walks on four legs, we want to limit that recommendation is 18 ounces or less per week. So it depends on your portion size. If you're someone who eats a small portion, a 3-ounce portion of cooked red meat, you can have it up to 6 times per week. If you like a little bit bigger portion, you can have it up to 3 times per week. A little note on grilled meats: grilling increases carcinogenic or cancer-causing compounds. So try and limit high heat cooking methods. Try and do more like baked and slow cooker methods. But I know summer's right around the corner finally. And if you are going to grill meat, just use a citrus marinade that can lower the development of the carcinogenic compounds. You also want to limit or avoid processed meats. And processed meats are any meat preserved by smoking, curing, salting, or adding any chemical preservatives. So that's your smoked salmon, your sausages, your breakfast meats, hot dogs, deli meats. And the recommendation is to avoid. However, that being said, if you are someone who has a hot dog at that one baseball game that you go to, that's not going to really significantly increase your risk. It's just looking at your overall diet. And if you have a good overall diet, you can occasionally have something like a hot dog or ham or bacon. To drink or not to drink? I get this question a lot. Alcohol itself is a carcinogen, and it also affects the lining of your GI tract, and that increases the permeability of your GI tract. So any carcinogen that you ingest along with it, it's easier for it to go into your GI system. The health implications of alcohol consumption outweigh any benefit you can derive from it. I know there's a lot of like red wine has heart health benefits. The American Institute of Cancer Research says that there's really no safe level of alcohol consumption where the health benefit is actually greater than any detriments it has. So the recommendation is to avoid alcohol to prevent cancers, because it's not just responsible for colorectal cancer, it's responsible for a whole slew of other cancers. That said, if you do choose to drink, no more than 1 drink per day for women and no more than 2 drinks per day for men. So now on to what foods decrease the risk of colon cancer. There's no one specific food that will decrease your risk. I know everyone's looking for that next superfood to include in their diet and what food is best, but really there's no one singular food. It's really diet overall. You want to include fiber, or the carbohydrate in foods that the body does not digest. You want to include antioxidants, which are chemical compounds of foods that protect cells. You want to include phytochemicals, which are literally plant chemicals that provide health benefits beyond basic nutrition. And you want to include calcium. Calcium is a mineral that we think of when we think of bone health, but it also can help reduce your risk of colon cancer. So foods that decrease colon cancer, you get your antioxidants, phytochemicals, and fiber from your fruits, vegetables, whole grains, nuts, seeds, beans, and legumes, so your plant foods. And then you get your calcium from dairy, of course, fortified plant-based alternatives, fish if you eat it with the bones, so like sardines, and then a lot of leafy greens. I did include an example of comparing a cup of cow's milk to a cup of broccoli, just to show you the difference in amounts in foods. So cow's milk has 300 milligrams. You need about 1,200 milligrams daily for good bone health. And that's the recommendation for intake for calcium. And when you're shopping for plant-based alternatives, always check the label. I have myself looked at plant-based yogurts, and they had no calcium in it. They had very little vitamin D in it. Vitamin D is essential to help with the absorption of that calcium. So when you look at your plant-based alternatives to dairy, always turn the label over, read it, check for calcium, check for vitamin D. You want the calcium to be about 30% of the daily value. So the recommendation is to aim for at least 5 servings of fruits and vegetables daily, which may seem like a lot, but I did include a picture to just kind of give you an idea of what 5 servings of fruits and vegetables look like. You want to make half of the grain servings that you eat from whole grains. If you have gluten sensitivity, you want to look up what whole grains you can have, because there are gluten-free whole grains that are allowed. You want to aim for more whole fruits and whole vegetables. I know a lot of people are fans of juicing. However, juicing really does take away the fiber. And when you take away that fiber, you are taking away some of the nutrition. Plus, we want that fiber for good gut and bowel health. So it's kind of not going to benefit you as much as eating the whole fruit or vegetable. The recommendations for fiber for every day, women, it's 21 to 25 grams. And then men, it's 30 to 35 grams. I know there are some products out on the market. My coworker brought to my attention, there's a pasta with 28 grams of fiber per serving. If you're eating your entire day's worth of fiber in one sitting, you're going to cause a lot of GI distress, and it's really not going to benefit you. So just aim for fiber space throughout the day so that you don't upset your gut. So tips: increase your fiber slowly, especially if you're someone who doesn't eat a lot of fiber to begin with. Begin with like 1 fruit or 1 vegetable serving per day. You also want to increase your fluid intake. Increasing your fluid intake will help prevent all that GI distress and help to moisten the fiber, making it easier to pass. I have had people increase their fiber without increasing their fluid, and that causes more constipation, more gas, more discomfort. And then you don't want to increase your fiber intake. So make sure you increase your fluid. Fluid goals are individualized. So I would say when you go to the restroom, or for a healthy person, when you go to the restroom and your urine is almost clear, you're well hydrated, you're hitting your goal. So to increase fiber, try adding beans, legumes, whole grains to salads, or even to sandwiches if you like sandwiches. Have fruit with cheese or nuts as a snack. That way you're getting your fiber and your calcium. And then emphasize the fruits and vegetables on your plate. Try and think of the meat as more of like a garnish or an accompaniment to that fruit and vegetable serving on your plate. If you're familiar with the My Plate method, that's a perfect example. There's also the American Institute of Cancer Research came out with the new American Plate, and it's very similar. It has, you know, your grains, your meat serving, and then your fruits and vegetables. I would also say go online, look for recipes, try what's in season. Maybe one of your goals will be to try one new food that's in season for a whole year and see what you like and what you don't like. Another question I get a lot is, what about supplements? So more isn't always necessarily better when it comes to fiber, when it comes to vitamins, minerals, all that stuff. Your body likes to get it from food because it's better absorbed from food. It comes in more absorbable amounts. And when you get it from food, when you get it from your fruits and your vegetables, you're also getting it along with those phytochemicals, along with those antioxidants. So we really want to make sure that we're eating our nutrients versus taking supplements. The research behind it shows that not all supplements provide the same benefit as food, and it's not always as absorbed as well as from food. So, like I said, diet and exercise go hand in hand. So I took the recommendations directly from the CDC website. So moderate intensity of activity for 30 minutes, 5 days a week, and 2 days of muscle strengthening activity. Moderate intensity means walking, gardening, light house chores, all that counts towards your moderate activity. Vigorous intensity activity, that's more of like your hard landscaping, your running, your jogging, and that's for about 75 minutes a week divided up as you see fit, and 2 days of muscle strengthening activities. You can do an equivalent mix on 2 or more days a week. If you're someone who doesn't normally exercise, always start slow, work your way up slowly. There's no shame in that. Start with 5 minutes a day, and know that 3 10-minute walking sessions is just as effective as 1 30-minute walking session. Okay, and I think we're going to take some questions.
Great, thank you so much, Lee. So we do have several questions that came in. I think the first one's for Dr. Friedman. And Dr. Friedman, are all polyps considered to be precancerous?
So yeah, for the sake of simplicity, all of them are considered precancerous. When we remove polyps, we always send them to the pathologist, and a pathologist is a type of physician that slices up those polyps and examines them under a microscope. And they look for any signs of what we call dysplasia. And dysplasia is a fancy term for the cells being more abnormal and being closer and closer to cancer. So sometimes we'll get results that are just adenomatous polyp, which I consider the most benign and the furthest away from cancer. And then we get polyps that have evidence of high-grade dysplasia or a high amount of abnormalities. And those patients will screen more closely. And again, it depends on the size, and we make sure that all of the margins or all the areas around it are clear of that dysplasia or that irregularity.
Great, thanks. And how significant is vitamin C and vitamin D for prevention?
I think that might be a question more for Lee.
There she is.
So vitamin D does help with the absorption of calcium. So making sure you have adequate vitamin D intake will help with the absorption of the calcium. Vitamin C plays a role in the support of your immune system. And in certain scenarios, not in every scenario, but in certain scenarios, your immune system is fighting off things. So there is always the potential that your immune system can fight off something that could turn into something greater.
Great, thanks. Next question, how can I prep without that disgusting salty drink?
So there, like I said, there's a variety of drinks, and there's actually pills. There's a prep called Sutab. Unfortunately, it's still 24 pills, so you kind of pick your poison. The Clenpick that I'd use is 2 5-ounce bottles. It's a sweeter drink, is what I've been told. I personally haven't ingested that, but there's a huge variety. If you don't want to do any of those options, there's over-the-counter Miralax, where you end up doing like a whole bottle of Miralax, but you can mix it in whatever you please as long as there's electrolytes. So if you love like lemon lime Gatorade, you can do a couple of glasses of that. You can do it with chicken broth. You can do it with Propel. You can do anything but water, because again, we don't want your kidneys to be affected by the prep. There's no way to do a colonoscopy or even that CAT scan, the imaging, without cleaning out your bowels, because we need to be able to see all the walls. And if it's not cleaned out well enough, it's an inadequate study, and then you don't want to waste your time.
Yeah, that makes sense. Can you have a colonoscopy without being sedated?
Absolutely. I had a patient that I saw last week that requested not to be sedated. She said for her last one, she wasn't sedated. For patients who have heart conditions, sometimes it can be safer that way. It's certainly not the most comfortable thing, and I personally wouldn't want it done, but it is an option. And there's also the option to start unsedated, and then during it, you say, you know what, I'm too uncomfortable, give me a little bit of sedation. So we're certainly flexible as long as you are comfortable, and our anesthesiologist, another type of doctor that's going to be present with us, is comfortable with the situation.
Okay. I'm going to kind of combine the next two questions. if you have a first degree relative who had colon cancer, how much is your risk increased? And for example, if your grandfather had colon cancer, what age should you start colonoscopies? Would it still be that 45 or would it be earlier?
So that's a great question. It depends on the relation. So first degree would be mother, father, sister, brother, children. If they have cancer and they're below the age of 60 on onset, which is hard to tell because if you're presenting at 65 with a bad cancer, you probably had it when you were younger. Those patients can be anywhere between 2 to 3 times increased risk of colorectal cancer. Whereas if you have a second degree relative, an aunt, an uncle, a grandparent with colorectal cancer, and they're above 60, it really doesn't impact your risk much at all. If they're below 60, your risk is slightly increased, but not to the same extent as a first degree relative. So usually our screening guidelines, we only bump you down to starting earlier if you have a first degree relative who's less than 60, or 2 first degree relatives that were greater than 60 years old, or if you have 2 second degree relatives who had colorectal cancer.
Okay. And then Lee, I think the last 2 questions that I'm seeing here for you. The first one is, what kinds of food should I eat after going through colorectal cancer?
So after going through cancer, it really depends on what type of treatment you have. If you had something like chemotherapy where you're still having side effects, you should modify according to those side effects. If you're not having any diarrhea, if your bowel function is close to normal, then I would start with increasing your fluid intake and then aim for a variety of fruits, vegetables, and whole grains.
Great. And then the last question I'm seeing here is, what about smoking or low heat cooking of meats? Does that also increase your risk?
So smoking does increase the risk. Low heat cooking doesn't create those carcinogens that high heat cooking does. So low heat cooking is better.
Great. Thank you so much, Dr. Friedman and Lee, for your very informative presentation this evening.